Chief, you can start.
Okay. Good evening, everybody.
Good evening, ma.
Good evening, ma. I think we have to start so that we can finish on time. It's always our desire that we end this meeting latest 8:30. We have 1 hour presentation and 30 minutes interactive session. So if we start early, we'll end early. So we can't keep waiting. So let others join us. Today is a special day because of the topic we are handling. You know, most times ABG usually stir up a lot of conversations and controversies. So we decided to get the best hand so that we can go through it again and have a better grasp of ABG interpretation. I know that some people joined cardio group recently, though I will still make this announcement at the end of this presentation, but it would be nice to say something about cardio group and say it again so that we all will be on the same page. This group came to be because of our desire to have a space, a learning space. After the event of JAPA, we know that a lot of cardiopulmonary physiotherapists left the country, and we now notice that some centers were left with 1 or 2 cardiophysios, and those that are interested in critical care. So out of that, you know, precarious situation we found ourselves, because I noticed some people were calling me from other centers to ask, you know, 1 or 2 questions with regards to the kind of patient they were seeing. So we felt it would be nice to have a space where cardiopulmonary physiotherapists can come together and share ideas from time to time, discuss their patients' confusion and all that. So when we started initially, we did not know that cardio group was going to grow like this. We just opened it, you know, just to see what happens. But good enough, before we knew it, group 1 got filled up. So there was this push again to open a second group. So we have cardio group 1 and cardio group 2. And the way we are going, there may be a strong temptation to open cardio group 3 because people are interested in learning, and that is what that has kept us going. People are interested to learn. People are looking for knowledge, and we know that knowledge is power. Knowledge is a very expensive currency. When you are knowledgeable, your head can stand on your shoulders, and we are very happy and privileged to have all of us on board. And I also want to express my appreciation to all of us that have been on the group. That group is a non-political or religious group. And so far, so good. We've tried to maintain decorum, because by the 6th month of opening cardio group, we now got a lot of international physiotherapists too. So we don't only have cardiopulmonary physiotherapists that are in Nigeria. We have some from South Africa, we have some from Tanzania, we have some from India. And we've also tried to get international speakers so that we can share ideas across Nigeria. So cardio group has grown into an international group. Meanwhile, it just started just like that. Then it got to a point, we found out that we cannot stay alone. We cannot just say that we are cardiopulmonary physiotherapists that are interested in cardiopulmonary cases and critical care, and we are just alone. That also made us to get some other professionals so that we can have a little bit of a multidisciplinary presentations. So in our group, we have pulmonologists, cardiologists, radiology, pharmacists, nurse, lab scientists, nutritionists. Yes, we have them. Then we have a lot of professors. So I am glad that we invited them and they came. And you notice that sometimes when we have some arguments, they also bring in their own, explanation, and it makes it very clear, and it helps us to practice better. I know that I've gotten some private messages from people that this group has helped. So I am very happy and glad to have all of us today. So we need to start now, and I'm going to introduce our speaker. We went very far to get this speaker, and we are glad that when we told him, without arguments, because he's a very passionate person when it comes to learning, he just said, I will do it. So we're very, very privileged to have him. So all protocols duly and rightly observed. Today we are privileged to have Dr. Okonna, a renowned anesthesiologist with extensive experience in critical care and perioperative medicine. Dr. Okonna has a track record of optimizing patient outcomes through expert management of complex cases. He will be sharing valuable insights on interpreting arterial blood gas analysis. This is a crucial skill for understanding acid-base balance and respiratory function. Dr. Okonna is a certified cardiac anesthetist and also a critical care doctor. He's a consultant anesthetist and an intensivist at the University of Nigerian Teaching Hospital, Enugu. He is also the head of units of both general and cardiac ICU. So we work with him in the ICU. So after his fellowship of National Postgraduate Medical College of Nigeria, he sub-specialized in cardiac anesthesia and critical care through a sponsorship program at Institute of Cardiac Science in India. He is also an American Heart Association certified instructor for basic life support and advanced life support training. And he has been training and mentoring healthcare and non-healthcare professionals with passion. He has a lot of, he has several publications to his credit. So if anybody needs serious training in basic life support or advanced life support, he does it, and he goes anywhere he's called to teach people so that he can equip people with the basic knowledge of saving a life, because we need to keep a patient alive before the doctor comes. So ladies and gentlemen, please join me in welcoming Dr. Okonna to guide us through this essential topic. Thank you. So sir, the floor is yours now. Thank you very much.
Yeah, thank you very much, and good evening, everyone. I hope I'm audible.
Yes, you're audible.
All right.
Yes, sir.
Yeah, I want to stand on existing protocols, and I want to salute your courage.
Sir, please, can you unmute your camera, sir? Sorry,
Is
sir,
it?
can you unmute your camera, sir?
I should unmute.
Yes, your camera.
Okay.
Thank you, sir.
All right, thank you. So I want to appreciate each and every one of us. Thanks for the privilege given to me to share with us on acid-base balance and analysis and interpretation. I want to salute the courage by the leadership, and then pleasure is mine to be here. Thank you very much. So I want to go in right away. So the topic before us is acid-base gas or ABG analysis and interpretation. Okay, so can we move to the next slide? So somehow we're going to be looking at this. We will look at the introduction, acid-base physiology, disorders and the effects. You know, so what does it do? So why are we worried about this acid-base balance? So why are we interested in learning about it? And then how does the body try to compensate or solve the problem on its own, even before our intervention? And then we will now take a little look, even though I know that many of us here may not be involved in taking samples, but it will be good if we actually have a little idea of how to collect arterial blood gas so that the result you get will be reliable and be trusted. And then we will now take some steps at interpreting arterial blood gas. So after that, we'll look at a few examples. So all of us will now contribute and then discuss and then see whether we have learned what we are discussing. Then we'll conclude. All right, next slide. So as a word of introduction, you know, ranging from our basic sciences or integrated sciences or biology or chemistry, we've been dealing with acid and base. Okay, so we'll discover that this understanding is very important to us. So we've been dealing with acid, and I say, what is an acid? An acid is a substance that can donate protons, that's hydrogen ion, while a base is a substance that can accept protons, that is, that can accept hydrogen ion. All right, so more often than not, we come across some terminologies like acidosis or alkalosis. Okay, so what does acidosis mean? Acidosis is a process of increased production of protons or increased concentration of hydrogen ion. That is acidosis. While alkalosis is a process of decreased production of protons or decreased production of hydrogen ions. So while acidemia is a process of a substance becoming acidic, is called acidemia. Alkalemia is a process of a substance becoming alkaline or basic. However, more often than not, when we are dealing with practical interpretations and explanations, you know, people don't really talk about acidemia or alkalemia. What you hear often is acidosis and alkalosis. Thank you. Next slide. Now, it is important we understand the basic physiology. The human body or blood maintains a normal or a balance of pH. And that pH at which all the enzymes and catalysts in the body functions well and optimally is pH of 7.35 and 7 to 7.45. It's a range. And so when you have a pH coming down below 7.35, we say that the body or the blood is becoming acidic, so it is called acidemia. And then when we have a pH more than 7.45, we say that the body is becoming alkalotic, and we call it alkalemia. However, our body tries to maintain a tight balance between this 7.35 to 7.45. And this process of tight balance is achieved by the body product called body buffers. So these are the things in our system, in our body, that try to work so hard to ensure that body's pH is maintained between 7.35 and 7.45. Next slide. So, and in our body, we have different types of buffers. We have intracellular buffers, and we have extracellular buffers. The intracellular buffers are the phosphates, while the extracellular buffers are the bicarbonate, which usually react to form carbonic acid. But we have the proteins which operate and functions both as intracellular and both as extracellular buffers. So the proteins functions as both intracellular and extracellular. Phosphate is intracellular, bicarbonate extracellular. And then what are these proteins? The hemoglobin, the amino acids, and the plasma proteins. They function at the level of both intra and the extracellular to be able to buffer the body's pH and to maintain the blood pH and to maintain it between a range of 7.35 to 7.45. And so, how does the body do this? This is by the function of the lungs or the kidney. Now, we have this equation which we have been meeting right from our chemistry days in school. And we are told that when carbon dioxide reacts with water, it forms carbonic acid. And when this carbonic acid differentiates, it forms hydrogen ion and bicarbonate. Now, the hydrogen ion is essentially removed to the kidney while the bicarbonate is retained. And so, the two body organ system that does this work of balancing is the lungs and the kidneys. How does the lung operate? The lung will blow off carbon 4 oxide. And then where does this carbon 4 oxide come from? It comes from carbonic acid disintegrating into water and carbon dioxide. And so the lung will take away the carbon dioxide. So when there is what? Acidosis, or when there is increased acidemia. Now, what the lungs will do is to be able to, react to blow off carbon 4 oxide. And this carbon 4 oxide is brought about by carbonic acid disintegrating into water and carbon 4 oxide. So while the kidney on its own hand, functions by when the carbonic acid also disintegrates on the other side, it forms hydrogen ion and bicarbonate. And so bicarbonate is retained, so thereby what? Becoming what? More alkalotic. So that's what the kidney will do. It will retain bicarbonate and then take away the hydrogen ion. But in this equation, it's also important we understand, the Henderson-Hasselbalch equation, because that will help us to actually find out what happens when, pH is going up, or when pH is coming down, or when bicarbonate is increasing, or when carbon 4 oxide is increasing. But we are going to come to this Henderson-Hasselbalch equation, but it's important we understand that pH is equal to pKa plus log of bicarbonate over partial pressure of carbon 4 oxide. But to make it simple, you take away pKa, take away the log and the plus. So you now have that your pH is directly proportional to bicarbonate over partial pressure of carbon 4 oxide. So I will explain that when we now talk about compensation and balancing and what the body does. Next slide. So now it is important that if we say that our pH is equal to bicarbonate over partial pressure of carbon dioxide, that is a modified form. Now we have a mnemonic which we call the room. That room means that for anything respiratory, it means that the pH is in opposite direction with the partial pressure of carbon 4 oxide. That is RO. But if the problem is metabolic, it means that the pH is directly proportional or equal or equivalent So following this equation, we now say that pH is equals to what? Bicarbonate. So if bicarbonate is going up, pH will go up. That means the problem is what? Metabolic. But if problem is respiratory, if pH is going up, partial pressure of carbon dioxide will go down because it is what? Indirectly proportional. Next slide. All right, so how does these disorders result? How does respiratory acidosis? How does respiratory alkalosis result? Now we know that in our system, the central nervous system controls a lot of centers, the respiratory centers, the cardiac centers, and all the centers in the body. Now, whatever that can depress the CNS will what? Decrease respiratory rate. And when respiratory rate is decreased, there will be what? Accumulation of carbon dioxide. And when carbon dioxide accumulates in the system, the pH will go down. And that is a situation you now know that you will have what? Acidemia, because the body blood system is becoming what? Acidic, or in short form, we have acidosis. And so when we have it, we now have the pH is going down, and then the partial pressure of carbon dioxide is going up because it's going to accumulate because the body cannot send away carbon dioxide. And this occurs in situations of what? Toxicities. If we have drug toxicities like opioid overdose, like some poisonings, whatever that can you take, or overdose of sedatives. A typical example was what happened to Michael Jackson. Michael Jackson took an overdose of propofol, and then he had respiratory arrest and died from that effect. So because the CO2 built up in his system and he could not blow it off because he was in a deep sleep, it becomes toxic and then he died from it. So whatever that can depress the respiratory center will cause CO2 to accumulate, and then that will increase the body acidic process, and that will lead to respiratory acidosis. Other things are what? Neuromuscular disorders. For example, poliomyelitis, okay, or whatever that can affect the muscles of respiration. It could be neuromuscular disease. It could also be some paralysis, even trauma. Like you have some people who have spinal cord injury, and because they have spinal cord injury, they could no longer breathe well. And if such patient is not intubated and mechanically ventilated, over time there will be accumulation of CO2. So other things that can cause it is what? COPD, okay? Obstructive lung diseases. And once the person can no longer breathe out because CO2 is accumulating because of obstruction, bronchoconstrictions, they will lead to respiratory acidosis. Now, for respiratory alkalosis, anything that can excite the central nervous system or the CNS and will cause hyperactivity or hyperventilation, like fever, like sepsis, will cause respiratory alkalosis. Then things that will cause inflammatory lung diseases, like pneumonia, once it occurs, you now have hypoxemia that can lead to respiratory alkalosis. Pain, you know, some people, because they have thoracic surgeries, okay, and then if they are not breathing well because of what? Pain, they're having pain, they can't breathe, they are restricting muscle movement, that will now lead to so sorry, not restriction. Now when people have pain, one of the first reactions to pain is what? Hyperventilation. So when they breathe so fast because they are having pain, it will now lead to respiratory alkalosis. Next slide. Now, how does this metabolic disorder arise from pathophysiology? Now, it ranges from a lot of things. Metabolic acidosis can come from diabetic ketoacidosis, okay, or hyperosmolar non-ketotic diabetic mellitus, people who have uremia, people who have lactic acidosis, or overdose of salicylate or ethylene methanol. Those overdose of agents and drugs can lead to metabolic acidosis. Other things are total parenteral nutrition, TPN, or people who have excessive normal saline, like hypercalcululemia, when people now receive normal saline overdose. Okay, people with renal tubular necrosis or diarrhea, these things can lead to metabolic acidosis. But for metabolic alkalosis, vomiting, hyperventilation, hyperaldosteronism, or people who have overdose of bicarbonate, sodium bicarbonate, because some people may say, okay, somebody has acidosis, so you now want to correct. Because you want to correct, you now give overdose of sodium bicarbonate. That will now lead to what? Metabolic alkalosis. Diuretic overdose, okay, can also lead to metabolic alkalosis. Next slide. Now, why do we worry about acidosis or alkalosis? Why are we worried? No, we are worried because they have a lot of effect on our body systems. And I'm looking at the cardiovascular system. Now, what will acidosis do to the cardiovascular system? Now, acidosis will decrease cardiac output. How will acidosis decrease cardiac output? It is going to decrease systemic vascular resistance. And so when the peripheral vascular resistance is decreased, thereby causing what? Vasodilatation, peripheral vasodilatation. So when there is peripheral vasodilatation, now there's going to be decreased mean arterial blood pressure and decreased cardiac output. Acidosis can also affect heart rate. It will increase heart rate because it will lead to ventricular tachycardia. It will lead to ventricular fibrillation, and patients will have increased heart rate and can even go into cardiac arrest and death. So, and that is why we need to correct it. We need to understand what is going on and then be able to correct it. Now, acidosis, because it leads to decreased peripheral vascular resistance, it will bring about shock. And then this shock will not be responsive to a vasopressor. You know, many times when somebody is in shock, you see somebody who blood pressure is low, hypertension, you say, okay, let us give vasopressor. But when somebody has acidosis, even if you give a vasopressor, it will not work because of excessive peripheral vasodilatation. Now, to the lungs, it increases respiratory rate, it increases work of breathing, and it brings about fatigue. And patients can arrest because of fatigue. Now, it will lead to respiratory failure and actually increases pulmonary vascular resistance. And then that will now lead to hypoxemia. All right. So for the in the metabolic processes, it brings about hyperkalemia, increased potassium, and this increased potassium will bring about arrhythmia, ventricular fibrillation, and then arrest and death. Okay, so when you have acidosis in the system, it causes insulin resistance. You see somebody, the blood sugar will be hitting the roof. Despite the fact you're giving insulin, it will not be responsive because of what? Acidosis in the blood. Now, it also causes excessive stimulation of the central nervous system and then leads to coma and then unconsciousness and death. So for alkalosis, so why are we worried? Alkalosis will increase systemic vascular resistance. It will also increase heart rate. It can also lead to ventricular tachycardia, ventricular fibrillation, and then supraventricular tachycardia and arteriolar vasoconstriction. So while acidosis causes vasodilatation, alkalosis causes vasoconstriction. So none of them is too good. So we must be able to create a balance. It brings about reduced coronary blood flow. So the blood flow through the coronaries to the cardiac myocardium will be decreased. So the heart will be deprived of blood flow. And so that will lead to cardiac arrest. Alkalosis also brings about decreased respiratory rate and hypoxemia. It can cause hypokalemia, it can cause hypomagnesemia, it can cause hypocalcemia. Then it brings about excessive firing, seizure, tetany, and decreased cerebral blood flow and unconsciousness and coma. Next slide. So having this understanding, so it is important, like I was trying to explain before. So how does the body respond or compensate? I said, looking at and understanding the modified Henderson-Hasselbalch equation. So where pH is directly proportional to bicarbonate and inversely proportional to the partial pressure of carbon 4 oxide. So we discover that the kidney, once you have respiratory acidosis or you have respiratory alkalosis, the kidney will try to compensate. How does the kidney compensate? The kidney will compensate by what? Removing hydrogen ion and by retaining bicarbonate. That is what the kidney will do when you have respiratory acidosis. Then when you have respiratory alkalosis, the kidney will try to retain, instead of excreting hydrogen ion, it will try to retain hydrogen ion so that the blood will become more acidic. And then it will also try to excrete bicarbonate. So that's what the kidney will do. Down for the lungs, it's important for us to understand that once you have respiratory alkalosis or acidosis, the kidney response is not as brisk or as fast as the lung response when you have metabolic problem. So it takes kidney hours to days and at times weeks before there's proper response. Okay, but if the problem is coming from metabolic side, and now the lungs can actually respond so briskly, and then if you have the opportunity and the leverage of having a patient mechanically ventilated, you can actually determine the rate, determine the tidal volume, and then you'll be able to now help the lungs in sending away. So when you have metabolic acidosis, what does the lung do? The lung will try to remove carbon 4 oxide. And then when you have metabolic alkalosis, the lung will try to do what? Retain carbon 4 oxide by decreasing respiratory rate. Next slide. All right, so it is important to understand that determinants of the outcome, what happens, depends on the duration of this acidosis and alkalosis. And so because we understand, important factor that time plays, that's why we need to be able to monitor acidosis well by being able to do arterial blood gases for our patients who are being monitored. Okay, and then it also depends on the severity. Okay, it also depends on the functional status of the lungs and the kidney. Now, if you have a patient who is having, for example, a diabetic patient who is having maybe a metabolic acidosis, and then the lungs is also having pneumonia, of course, the lung may not be able to respond well to the metabolic acidosis because there is what? Functional status of the lung and kidney are not good. Or you have a patient who is, having respiratory acidosis, and then for one reason or the other, that person is in kidney failure, is going to complicate the problem. So functional status is a very major factor that determines what happens to the patient, and then underlining etiology and pathology. So it's important. So when we're managing this patient, we're able to now look at, okay, what actually is the functional status. Now, how do we take our samples? So it's very, very important because it depends on the purpose. What do you want the arterial blood gas for? Is it for a patient who is having hypoxemia? You are suspecting hypoxemia, for example, pneumonia. So you want to know the partial pressure of oxygen. If that is the case, you must take an arterial blood. But if it's a patient that is having maybe metabolic acidosis from DKA, yeah, you can actually take a venous blood. If you can't take arterial blood, you can take a venous blood, and it will give you an idea of what is happening, whether there is acidosis or whether there is alkalosis. So because you don't really need PO2 so much in that scenario. All right, next slide. Now, so uses of arterial blood gas. So the test is used to determine the pH of the blood, the arterial pressure of carbon dioxide and oxygen. So there are so many components that we can actually look at. So arterial blood gas can actually give you, depending on the machine you're using, and then also depending on the cartridges, because some of them have different cartridges. For example, if you're using iStat to check for the arterial blockers, you have cartridges that will give you lactic acid and blockers. Then you have a cartridge that will give you electrolyte and blockers. You also have a cartridge that will give you maybe urea creatinine, okay, and blockers. So depending on what you're doing, so that determines. So we have different types of arterial blockers analyzer that comes in different formats. So all the tests or parameters they give are not same. So it depends on the machine, depends on the company, and then also depends on the cartridges you are using. So, but for whatever, they play an essential role in emergency and critical care. Okay, and then also for pulmonologists, and then for patients who are managing the heart, probably chest infection, chest condition, and then cardiac problems. Next slide. So, like I said, you can actually take arterial blood or a venous. Whether you are using an arterial blood, now these are the ranges. If you're having an arterial blood, the pH I gave us before is for arterial blood, which is 7.35 to 7.45. But if it's a venous blood, you can have a pH of 7.31 to 7.41. For PO2, it's usually 80 to 100 millimeter mercury for arterial blood. But for venous blood, it's 35 to 40 millimeter mercury. For partial pressure of oxygen or of carbon dioxide, is 35 to 45 millimeter mercury, and then 41 to 51 millimeter mercury for venous blood. Bicarbonate is essentially the same for whether it is arterial blood or venous blood. Then base excess are also essentially the same, whether it is an arterial blood or venous blood. Then, like I said, other parameters that you can get, electrolyte, lactic acid, creatinine, on all those things, depends on the cartridges and depends on the machine. But these are the basic blood gas that is being measured. Next slide. Now, sampling procedure, where, like I said, you usually take consent, and then the commonest area is the radial artery, okay? And then before you do it, you perform what we call Allen's test. Allen's test helps you to be able to know if, assuming the radial artery has a problem, would there be collateral from the ulnar artery, so that you don't have a maybe somebody whose radial artery is damaged, and then that part of the lateral part of the palm is not being supplied. So that's why you perform the Allen's test, and then you do a gentle prick, then aspirate the blood. But it's also important that when this sample is collected, prompt testing and analysis should be done. You don't delay so much when you collect arterial blood. We want to make sure that there is no air bubble inside the syringe or inside the container. That's why it is better to use a syringe. Some people collect arterial blood gas in a container, but it's not really an ideal setup. Okay, next slide. Okay, so once you do it, you must have what? A heparinized syringe. If you have a heparinized syringe and you collect it, it is advisable that it is interpreted or analyzed within 30 minutes. Now, if for any reason the sample could not be analyzed within 30 minutes, then it must be in a glass syringe, preserved in an ice or frozen section. So when you have just a container with a sample and you say you want to use it and run arterial blood gas, it's not really an idea, because inside that container there are air, and this air will continue to mix with the sample you have collected. So that's why when you collect it with a heparinized syringe, you actually make sure that there is no air. You push the blood up until there's no space above the syringe. You see blood coming out from the needle. That is when you now cap the needle and then take it immediately for analysis. Next slide. All right, so once analysis is done, okay, you're going to have your pH, partial pressures of oxygen and carbon dioxide and bicarbonate, and then the electrolytes, and then other ones, depending on whatever cartridge or analyzer you have. Next slide. Okay, so errors. There are certain things that can introduce errors, and these include what? Heparin. If you have excessive heparin, okay, it's going to dilute the what? The electrolytes that you have collected. So you may now have what? Sodium heparin, giving you what? Elevated sodium. Okay, assuming you are getting electrolytes in that sample. So then heparin can also bind to cations like calcium and potassium. So it is important you have this knowledge so that when these samples are collected, you now be able to now know what is also. So the syringe must not have plenty of heparin. You draw heparin with your syringe and you push it out from the needle. You just want to have some heparin passing through the needle, not really that you're going to have some heparin inside syringe. All right, next slide. So other causes of errors. Now, if you have air bubbles, like I said, it's going to affect the result you have. It's going to dilute, okay, the pH will follow the partial pressure of carbon dioxide. If the blood PO2 is high, okay, it will now, that's above 100 millimeter mercury, there's going to be a decrease in PO2. But if the blood PO2 is low, it will start increasing. The same thing happens with partial pressure of carbon dioxide. If there is air inside the syringe or whatever container, and then if you have high partial pressure of carbon dioxide, then the one you're going to get will reduce. But if you have low in the blood, it's going to increase. Next slide. Now, okay, you should not delay, okay? For every 1 hour delay in analysis, then the PO2, partial pressure of oxygen, will decrease. pH will also decrease, you know, by 0.05 units. And then the PO2 will now start increasing because there is a delay. Of course, there's going to be a reaction inside the blood in that container because it is delayed. All right, next slide. So how do we interpret? Because this is also the meat of the matter. How do we interpret? So it is important to do what? Follow a methodical approach. So you first of all look at the pH and decide whether there is what? Acidosis or whether there is alkalosis. Whether there is acidemia or whether there is alkalemia. All right. You now second, you try to identify the primary disorder. Is the problem respiratory? Is a problem metabolic? By looking at what? The modified Henderson-Hasselbalch equation, where pH is directly proportional to the bicarbonate or inversely proportional to partial pressure of carbon dioxide. Then you identify whether there is what? Compensatory process going on in the system. Is the body trying to compensate or the body not trying to compensate? Then you also look at what? You try to calculate anion gap. If it is metabolic acidosis, you try to calculate anion gap. Okay? And then you also look for what? Additional disorder by looking at what? Delta anion, okay, gap. Because if there is what anion gap, you now want to see, calculate the delta anion gap, and then that will now tell you whether there's what? A mixed condition, whether there's additional problem. Next slide. All right, so like I said, if you get your arterial blood gas sample or report or print out, you now want to look at the pH that is there. Once you see pH less than 7.435, you say there is what? Acidemia or acidosis. Okay. Once you see a pH that is above 7.45, you say there is what? Alkalemia or alkalosis. Okay. When you have a normal pH within 7.35 to 7.45, it does not rule out abnormality. It's very important you understand it, because some people will tell you the pH is normal. No, you ask yourself, yes, pH is within range, but is it tending towards the acidic side or is it tending towards the metabolic side and alkalotic side. For example, if you have pH of 7.36, in as much as it is normal, it is towards the acidic or acidemia. Now, if you have 7.35 exactly, yes, it is normal, but it is towards. So you will now look at other parameters to now see, is it because there is a problem and the body has reacted to compensate it, or what? So that's why it is important that there is a normal pH does not rule out abnormality. Next slide. All right, so like I said before, so you look at this equation. So if you have a pH, pH is going down. How is it going down? It is less than 7.35. You tell yourself that is what? Acidemia or acidosis. Okay? You now ask yourself, what is the relationship with what? Bicarbonate, and the relationship with what? Partial pressure of carbon 4 oxide. If you now follow our mnemonic rule, RO, I said if it is respiratory, because we're now looking at primary problem. If it is respiratory, okay, pH is going to be what? Opposite PCO2. But if it is metabolic, pH is going to be equal or equivalent or directly proportional to the what? Bicarbonate. Next slide. Okay, so having determined the primary problem or pathology, saying, okay, it is what? Primary respiratory problem, or you say, okay, it is what? Primary metabolic problem. You can now ask yourself, is there compensation going on? All right, now, essentially, if you have a metabolic process, the respiratory component is supposed to compensate. For example, you have pH is going down, PCO2 is going up. What will happen? Now, the metabolic component will now compensate. What will the kidney do? The kidney will try to conserve bicarbonate, retaining bicarbonate. So bicarbonate will start increasing. Okay, so once you see bicarbonate increasing, all right, it tells you that the body is reacting. But if bicarbonate is within normal range, despite the fact that PCO2 is going up, pH is coming down, you now say that the body is not responding. There is no compensation. That is the simple way of looking at it. However, if you want to do by calculations, you can actually do some basic calculation to now tell you, yes, what is the degree of compensation. So if you have metabolic acidosis, for example, all right, the body will try to compensate by the respiratory process, trying to do what? Conserve, blow off carbon 4 oxide. And so if there is blowing off of carbon 4 oxide, the PCO2, partial pressure of carbon 4 oxide, that you are going to have in that ABG analysis should be equivalent to 1.5 times the bicarbonate that is in the result plus a factor of 8 plus or minus 2. That is called Bentley's formula. Bentley's formula is actually used to calculate and then look at degree of compensation. Okay, when there is metabolic acidosis, degree of compensation by the what? By the lungs, trying to do what? Blow off carbon 4 oxide. Now, if you have metabolic alkalosis, now there is going to be what? Because there is what? Metabolic alkalosis, so the kidney is retaining carbon 4 oxide. So the lungs will try to do what? Retain also PCO2 by not blowing it out, so that it will tend to go into acidosis. Okay, that's a means of compensation. So if you have increase, okay, of PO2, PaCO2 of increase by 7 for every 10 millimeter equivalent per liter increase in bicarbonate, then it shows that the compensation is adequate. Next slide. All right. So for the respiratory acidosis, all right, actually, I want to ask yourself, is there compensation? I said, if there is respiratory acidosis, what will the kidney do? The kidney will try to do what? Retain what? Bicarbonate. So for acute acidosis, the bicarbonate will now be retained, and the increase in bicarbonate by 1 shows that the problem is what? Is acute. There's what? Acute respiratory acidosis. Okay, but when there is a chronic acidosis, it means that the increase in bicarbonate will be up to 3 or more when there is an acute problem. So the same thing when you have respiratory alkalosis, all right, for every 10 millimeter decrease in partial pressure of carbon 4 oxide, if it is acute, the bicarbonate will go down by just 2. But if it is chronic, bicarbonate will go down by 4 or above. Next slide. So step 4, the next thing is not for us to look at what? Anion gap. That is a measure of unmeasured anions or proteins, phosphate, sulfate. But to make it simple and brief, we say that anion gap is calculated by what? Sodium plus potassium minus bicarbonate plus chloride. So once you have the value of sodium, potassium, and then bicarbonate and chloride, then it can give you, do the calculation. So how do you get it? Normal anion gap or value is between 8 to 12, or simple, less than 12. Once it is less than 12, it is normal anion gap. If it is more than 12, you say there is what? Anion gap. That is for when you have metabolic acidosis. That is when you start calculating anion gap, when you have metabolic acidosis. And remember the things that can cause metabolic acidosis: DKA, uremia, lactic acidosis, ethylene, glycol, salicylate. So once you have any of those things, you are looking at what? Metabolic acidosis. So you want to ask yourself, is there anion gap? Is there so high anion gap metabolic acidosis? All right. So next slide. So if there is what? High anion gap metabolic acidosis, you can now ask yourself, is it just simple problem or is it a mixed disorder? So when you have you can have mixed disorder because maybe when there is what? Absence of compensation, excessive compensation, or long-standing pulmonary or renal disease, or when there is assisted ventilation. Okay, so you now start suspecting there is what? A mixed disorder. Next slide. So how do you calculate, okay, delta ratio? So delta ratio will help you to find out whether there is what? A mixed problem. So how do you get it? You get it by doing what? The calculated anion gap. That is so delta ratio is delta anion gap over delta bicarbonate. So how do you do it? So whatever anion gap you have calculated, you subtract 12 from it because it's high. So because it's high, you subtract 12 from it, and then you now do 24, which is the middle range of bicarbonate. Remember, bicarbonate is from between 22 to 26. So the middle range is 24. You now do 24 minus the calculated bicarbonate. So if you have bicarbonate a ratio that is less than 1, you say it is pure anion gap metabolic acidosis. If it is delta ratio of 1 to 2, you say there is what? Mixed anion gap and non-anion gap metabolic acidosis. But when you have a ratio that is greater than 2, you say there is anion gap metabolic acidosis with metabolic alkalosis. Next slide. All right, so we're going to do some calculations here now. I don't know, some people may have to unmute themselves so that we can do the calculation together and solve it. Let's do the interpretation. That will now help us to know if we are following what we are doing. So the first example here is we have pH of 7.35. So if we go by saying, is it acidosis or is it alkalosis? Is it acidemia? Is it alkalemia? What will we say? Somebody.
Normal.
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 It's
Okay,
tending
fine.
towards acidic.
Yes, it's normal range, but it is towards acidic, correct? Okay, normal range towards acidic. Okay, now PCO2 is 30. So what is it? PCO2. What is it?
It's reduced.
Yes.
Alkali.
Yes, it's a alkalotic because the normal should be what? 35 to 45
To
millimeter
45.
mercury. Yes, but it's now low. Okay, it is low. Okay, now, okay, thank you. So now the bicarbonate, what is bicarbonate? Bicarbonate is 16. Acidosis. All right. So now, if you look at this pH, it is what? Even though it's normal, it's going towards that. It's going towards acidosis. Now, so pH is going down. Bicarbonate is going down. Are they equal or in opposite direction?
Equal direction.
In equal direction. Okay. So essentially, what you have here is what? Metabolic acidosis. All right, metabolic acidosis. But now, if you look at your PCO2, PCO2 is down because the respiratory center is already trying to compensate by going down because there is what? Metabolic acidosis. So it's trying to compensate by blowing off the PCO2. And because it has blown off the PCO2, that's why PCO2 is now down. So if you have this kind of picture, you now say this patient has what? Fully compensated. Fully compensated metabolic acidosis. Are we together?
Yes, sir.
Yes,
Yes, sir.
Yeah, fully compensated because what? pH is going down. All right. Now, PCO2 is going down. It is in the same direction, so it cannot be a respiratory problem. Agreed?
Yeah.
Because,
Yes.
Agreed.
yes,
Yeah.
if it is a respiratory problem, it should be in opposite direction. Do you understand? Yes, but it is in the same direction with what? With the bicarbonate. So it is a metabolic problem. So this is a metabolic acidosis. But the lung is trying to compensate by blowing off, and it has been able to restore the pH to normal. So we say it is what? Fully compensated metabolic acidosis. All right?
Yes, sir.
We together?
Yes.
All right.
Yes.
So let's go to the next one. Let's finish with acidosis. Then we can now, if we want to do anion gap, we can do. All right. But if you want to do the anion gap for this, you do 148 plus 3. You sum them together, and then you now do 16 plus 110. You sum them together, you subtract. When you subtract it, it will not give you what? The anion gap. If it is more than 12, you say there's what? Anion gap metabolic acidosis. All right?
Yes.
Okay.
Yes, sir. Yes.
So let's look at the second one. pH is what? 7.29. Okay.
It's acidic.
Acidosis is what?
Yes, sir. It's acidotic.
As acidosis. So
Acidosis.
yes. So here now, if we follow the modified Henderson-Heidelberg equation, so pH is coming down, right? All right.
Yes, sir.
PCO2 is 48.
Acidotic.
Acidotic.
It's going up.
So
Alkalotic.
so what is it?
Acidotic.
It's respiratory acidosis. No, don't rush. Don't run. Just take it easy. So now we see pH. pH is what? 7.29. So it is coming down.
Yes.
PCO2 is 48. So it is going up. So they are in opposite direction. So what do you say is the primary condition here?
This is respiratory acidosis.
Respiratory.
Respiratory acidosis.
Yes,
Always.
this is respiratory acidosis, correct? Respiratory acidosis. Okay, fine. Now bicarbonate is what? Bicarbonate is 28. What is the normal bicarbonate?
22 to 26.
22 to 26. So in other words, the bicarbonate is going up. So because it's going up, it is trying to compensate, because the kidney will compensate for respiratory acidosis by doing what? By retaining and yes, and taking away hydrogen ion. So, but this increase it is trying to do has not been able to successfully bring pH back to normal. So, what are you going to say this condition is?
Partially compensated respiratory
acidosis. Correct. This is partially compensated respiratory acidosis. Okay, because there is so it can actually help you to do this instead of going to now do the calculation of Bentley's formula, using the Bentley's formula to do calculation. Just looking at all the components will tell you whether there is an attempt to correct, or whether there is full correction, or whether there is partial correction, or whether there is no correction at all. Okay. Now let us look at the next one. The next one. pH is what?
7.43.
7.46. So 7.46 is what?
Tending towards alkalotic.
Going towards alkalosis.
Anemia. Okay, fine. PCO2.
acidotic.
Acidosis.
No.
Is acidosis.
Acidosis.
Wait.
It's acidosis.
No, it's
It's
too low.
going down. It's too low.
PCO2.
Alkalotic.
Hello. Okay, now. So PCO2 normal value is 35 to 45. So it is going down. Okay.
Yeah.
And because it is going down, when PCO2 is going down, it means, yes, it means alkalotic. Yes, it means alkalotic. But when it is going up, it means acidotic. Yes. So for here, but now look at the pH value. pH value is what? Is increasing. pH value is increasing, right?
Yeah.
This PCO2 value is doing what? Is decreasing.
Yeah. Then
Yes.
nucleus is trying to compensate.
So there are what? Inverse ratio. Because pH is increasing, PCO2 is decreasing. It's a primary respiratory alkalosis. Are we together?
Yes,
Yes,
sir.
sir.
Yes, it's a primary respiratory alkalosis. Now, because it's primary respiratory alkalosis, the kidney will do what? Compensate. By doing what? By blowing
hydrogen.
Bicarbonate will begin to go down. The normal bicarbonate is what?
22 to 26.
22 to 26.
And now what we have here is what?
21.2.
So it's making an attempt to compensate, but it has not done enough.
Yes,
Yeah.
sir.
So you now say that this is also what? Partially
Partially compensated. Respiratory alkalosis.
Yeah, that is it. Now the next one. pH is what?
Alkalosis.
7.5. So which means it is going up,
Yes, sir.
right? It is what?
Yes.
Going up. Okay. Now, PCO2 is what?
It's normal.
CO2
Normal.
within the
Yeah,
normal.
normal.
Yes.
It's normal. Now, the bicarbonate is what?
It's going up.
It's
Is
increasing.
up. Is higher. Up. Going
Alkalosis.
upwards. So
So
Hmm?
it is going in the same
Alkalosis.
direction with what? pH.
with the pH.
pH. So it is directly
Meaning
proportional.
it's
Okay. And
metabolic disorder.
because it is directly proportional, it is what?
Metabolic alkalosis.
Metabolic
Yes.
alkalosis.
Metabolic alkalosis. Okay. But now, PCO2 is what? 38, which is within normal range.
Normal.
Yeah.
So the body did not make any effort to.
Yeah, uncompensated.
This is uncompensated
It is metabolic.
Metabolic
Metabolic
alkalosis.
alkalosis.
Are we together?
Yes,
sir.
we are.
Okay. Now we'll do the second to the last. Second to the last. So pH is what?
Is acidic.
Acidosis.
Acidosis. So
That's
pH,
just
yeah, it's acidosis. pH is going down. So it's acidosis. Now it's going down. Now PCO2. PCO2
Is also going down.
is going down.
Alkalotic.
Is going down.
Alkalosis.
Okay. Now bicarbonate is also
Is
going
also
down.
going
going
down.
down. Ah,
Acidosis.
Okay. So who will tell me what is this one now? What is
Is mixed.
it's uncompensated metabolic acidosis.
Metabolic acidosis.
Yeah. Is this a uncompensated?
Mixed acidosis.
Is it uncompensated?
It's uncompensated.
Okay,
Yes.
it's
Is it
uncompensated.
uncompensated?
Yes, it's uncompensated.
PCO2 should be 35 to 45.
Exactly.
So the body is trying to blow off CO2. It's trying to blow off CO2 to be able to bring that pH to normal. But it has not been able to achieve it. So there's a reaction from the body. If it is within 35 to 45, you say uncompensated. But this
If
time,
it is not.
Going down. Okay.
it is going down. So it's trying to blow off.
So it's fully compensated.
It's
Mhm.
what?
No, partial.
It's partial.
Partially, yes, it's partial.
Yeah,
It's
it's partially
failed.
compensated.
Yes.
Okay. Okay. So, let somebody now volunteer to do the last one for us. Who will volunteer? We need a volunteer for the last one. The last one.
Metabolic alkalosis. Acidosis.
Yeah. It's what?
So let me make a try.
Metabolic acidosis.
Fully compensated metabolic acidosis.
Fully compensated metabolic acidosis. Is it fully? pH has not come to normal. So it is not full.
Partially.
Okay, so it's still partial.
Yeah, it's still partial. If you have 7.35, you say it is fully compensated. But it has not, it's not full yet.
Okay, sir.
Even though the lung is trying to conserve the CO2 to increase the acidity.
Yes.
Yes. Yes. So it's trying to. So no, sorry. I'm confusing us. No. What did you say? What did you say? The answer?
Initially, I said fully compensated. You said it's not fully compensated.
No, it's not fully compensated though.
Yeah, you said it's partially compensated.
No, it's not even partial because it's within normal range.
39 is normal.
It's
39 is normal.
So that's uncompensated.
Uncompensated. Yes,
It's uncompensated.
Yes.
Okay.
Uncompensated metabolic acidosis.
Acidosis.
Yes. Because bicarbonate is low, pH is low in the same direction. So
Yes, sir.
So metabolic what? Acidosis. Then but the PCO2 is within normal range, so it's not doing anything yet. Okay.
Okay.
It's not doing anything. So if you have like 30, you say it is what? Partially compensated. So this one is
Okay.
what? Uncompensated. Then if you want to calculate, because it's a metabolic acidosis, if you want to calculate delta ratio, I'm sorry, anion gap, you can now do what? Sodium plus potassium, which is what? 132 plus 3. That will give us 135. 135. Now 135. So then the bicarbonate is what? Is 14.
14.
Then chlorine is what? 109.
109.
If you add them together, what will it give you?
123.
Eh?
123.
So 135 minus 123, what will it give you?
12.
That's
It is what?
12.
12. So it is what?
Yes, sir.
Normal anion gap, metabolic acidosis. Normal anion gap, uncompensated metabolic acidosis.
Acidosis.
Do you understand?
Yes,
All right.
sir.
Yes.
Next slide. Okay. So knowledge of ABG, okay, analysis and its interpretation is crucial in the management of critically ill patients and its application relevant for successful outcome. All right, next slide. Next slide. Are you still there? If you're still there,
Yes,
ask
sir.
your, ask your
Yes, sir.
question. So ask your question.
Wow. Beautiful.
Thank you
Amazing.
so much. Wow.
Thank
What a
you
Thank
so
you
much,
so much,
sir.
sir.
John. Please, can we appreciate him with any emoji of our choice? I know we are glad to have participated, and I
Yes,
was
so
quite
glad.
happy. Yeah. So thank you, sir, for the presentation. We'll not waste time because we have less than 15 minutes. Can we get questions, comments, contributions? Maybe Dr. Okonna, I don't know if you need to take it down. Maybe you need to take that.
I will.
Someone just sent me a question. He said, what is the relevance of anion gap in ABG on interpretation and analysis? What is the relevance of anion gap? As in, why do we need to calculate it? So if you have a question, can you indicate by raising your electronic hand up? You can take the question. Okay, Joy. Joy, can you ask your question? Then after Joy, Dr. Nwafo, you can ask your question. Joy, can we have your question?
All right. Thank you, Ma. Thank you so much, sir. We really appreciate the presentation. It was very, very insightful. Honestly, you helped clear a lot of gray areas for me in interpreting ABG. So straight to the question. As a cardiopulmonary physiotherapist in practice now, having interpreted this ABG for my patients, how will it help? I know you're a doctor, okay, but what would be the inference for me to bear in mind when I'm managing a critically ill patient? For example, like the last one we just did, where you said it's an uncompensated, I think metabolic acidosis, for example. Now, so what would be the inference for me as a physiotherapist when I get into the ICU or in a critical care center and I see such values? What would it imply for me in planning the treatment of my patient? Does it mean I can't attend to them at that time, or I just have to closely observe, or can I still carry on whatever I need to do in terms of my management as a physiotherapist? Thank you.
Okay.
Should I go ahead?
Yes, go ahead.
Okay, thank you so much, my dear boss, Dr. Okonna. So I'm not surprised on what you can do. You always teach us and you continue to teach us. Thank you so much for a very good presentation. And I want to so that we've been going through corrections when we interpret the ABG, how do we make corrections? And
Sorry,
also,
I can't hear you. I can't hear you.
I feel like we didn't dive
Huh?
into corrections when we really interpret the ABG.
Yeah. Okay.
And another one is when we observe partially compensated acid-based disorder, do we go ahead to make corrections or not? Thank you.
Okay. Okay.
Excellence. I noticed you raised your hand. Can you go on and ask your question? Then after that, Chidera, you ask your questions, and Karim, you also ask your question. Let's have the question from Excellence.
Okay, good evening, sir. I just want a quick one. Can any blood infection or blood disorder affect the accuracy of ABG results? Can any blood infection or any blood disease or disorder affect the accuracy of ABG results? Thank you.
Okay.
All right, Chidera, can you ask your question if you are still with us? Chidera, are you there?
I'm there. Can you hear me, ma?
Yes, I can hear you. Please ask your question.
Good evening.
Good
Okay,
evening.
I said, can any blood infection or blood disease or any blood disorder affect the accuracy of ABG results?
Okay,
Okay.
thank you.
Okay. Noted.
Karim, can you ask your question if you are still with us? Karim? Okay, Innocent, you can take your question.
Okay. Good evening, everybody. Thank you very much, Dr. Okonna. I've known you for a long time now. Even back in Memphis, I know you do a very great work. But there's a question I wanted to ask. When you were interpreting those test results, you gave so many examples of so many ABG results. At that point in time, we had so many people actually giving an answer to it. He he actually muted what you were even saying. What you were saying was very, very loud low, while everybody's mic was open. So I couldn't get some things, especially the third to the last, no, the fourth to the last and the second to the last. I couldn't get it because I was just trying to listen to your voice, but other voices were too much that knows it more than other people in the group. So I personally I wasn't getting your voice anymore. So I wanted to get your voice, but I was getting surrounding voices which I could not actually uh, even if you tell me right now what is the fourth one to the last and the second one to the last, I may not be able to give a correct answer to that one. Try to meticulously listen to it. I was hearing other voices. I know everybody knows it, but at least they could have just lowered down a little so that we too, that is we that you don't know it, might actually follow up. That is what I just wanted to say about that one. If you can actually recap those ones, why everybody keep their mind down. Thank you.
Okay. Please,
All right.
Dr. Okonna, a question online.
Okay.
Person said, how do we work with friends? How do
Yes.
we work
Yes.
with people to treat?
Yeah. I can. Yeah. I can start with that one. Let me start with that
No.
one.
Can you take your last question, which is should come from Aisha? Aisha, are you there? I hope I'm pronouncing your name well. Okay,
Yes,
can you?
ma'am.
Okay, ask your question, please.
Okay, good evening, ma'am. Good evening, sir. Sir, thank you very much for this wonderful knowledge. We are really glad and we appreciate. Sir, regarding the partially, fully, and uncompensated, um, the last calculation that we did, So I didn't get the partially compensated, the fully compensated, and uncompensated from SAR. So if you can also simplify it just like you simplified everything, I'll be very glad. Thank you.
Okay.
All right.
The last question. Can we all mute our mics so that we can get answers to these questions? Thank you.
Yeah. Okay. And then maybe the person is sharing the slide. You can turn to those examples, that slide with examples, so that as I answer the questions, then maybe we can now solve the last two together. I will now give us explanation for the last two. Okay, so let me start with the one of the questions here says partially or fully compensated. Okay, that you don't understand what it means. Now, when we talk about partially, we said the body is making effort. That was why I first of all gave us the normal range for those values, for pH, for PCO2, for PO2, for bicarbonate, okay? So that we know the normal, so that when there is a derangement, you now know. Now, ideally, I also told us how does each of the body component compensate. If you have a primary problem in the respiratory, now the kidney will want to compensate. If you have a primary problem in the kidney, the lung will try to compensate. So if you have respiratory acidosis, which means pH is going down, PCO2 is going up. Now, how will the kidney compensate? By taking away hydrogen ion and by retaining bicarbonate. So bicarbonate will start going up. So if bicarbonate does not, it's not seem to be going up, it means there is no compensation. If bicarbonate is normal, it means it is uncompensated. If it is going up, but pH is still not normal, it means it is partial. If it has gone up and pH has come to normal, it means there is what? Fully compensated. Okay, so the same thing, if the problem is what? Respiratory alkalosis. So the kidney will do what? We try to blow up carbon dioxide and retain hydrogen ion. So the same thing will happen if the problem is what? Metabolic acidosis. The lung, because the pH is going down, bicarbonate is going down, that's metabolic acidosis. Then the lung will try to do what? Accumulate CO2. So CO2 will be going up. If CO2 is still normal, it means the lung is doing nothing. But if CO2 is going up, but pH has not come to normal, it means it's partial. If the CO2 is going up and pH has come to normal, it's fully compensated. Okay, so that is the way I want to answer that. So now, how do we work with the vent to treat respiratory acidosis or respiratory alkalosis? Now you have a patient that is on ventilator, and that patient is having what? Respiratory acidosis. What do you do? CO2 is going up. So you want to blow off the CO2. You increase respiratory rate, you increase the tidal volume. When you do it, if you have a capnograph that is connected to the patient, you will see end tidal CO2 will start coming down. All right? Because what? The tidal volume has gone up, which means the minute volume will go up, the respiratory rate will go up because you are now blowing off. By increasing rate, you blow off CO2. Do you understand? Now, if you now discover that this patient maybe is not tolerating the setting. For example, you want to increase rate and increase that volume, but because you increase the rate, maybe the vent is making noise or patient is not accepting it, you can decide to paralyze this patient. You take over. So you can decide the rate and decide the tidal volume you give. This is one of the things that can be done. So the same thing vice versa. If the problem is what alkalosis, maybe somebody is hyperventilating, blowing off CO2, you're having respiratory alkalosis. So you bring down the rate, you bring down the tidal volume, thereby allowing CO2 to accumulate. The end tidal will start going up. So that is what you do. That's how to use the vent, okay, to treat respiratory acidosis or respiratory alkalosis. Now, blood disorders affecting the result. Yes, if you have, for example, I came down from First Cardiology, Lagos, where we had open heart surgery, and they discharged with pathology of palate, and because they usually have hypoxia, and because of hypoxia, you have polycythemia, you understand? And because of the polycythemia, so the blood, you have hypercoagulable state. Once you're collecting the sample, it's clotting. So if you don't collect the sample well, by heparinizing your syringe, if you collect it, the sample will clot, and you cannot analyze, okay? Or you may analyze and then it will not give you some values because it cannot make out what is there. So these are in some of the ways that some certain blood disorders can affect, okay? But if it is just infection, infection naturally should not be able to affect. Infection should not, okay? But some blood disorders can. Now, Dr. Wafo, I didn't really get details of what you say partial disorder or correction. I didn't get it well because your voice was not quite clear.
I said when there is a partially compensated disorder, you need to correct.
What will you do? Okay, yeah. If it is partially compensated, of course, you try to, so long as pH is not normal. I told us the danger of acidosis. I showed us the danger of acidosis and danger of alkalosis. So we don't need it. If it is partial, anything you know you can do to make it fully compensated, you do. Do you understand? That is the ideal thing. Okay. However, it is not maybe when you see maybe pH of maybe 7.34 just decrease by 1. You now say you want to start giving bicarbonate, and then maybe bicarbonate is maybe even on 30 something because it is a respiratory. No, in that situation, you may just decide to, if the patient is on ventilator, you may just decide to use ventilator setting instead of giving sodium bicarbonate. Now, if somebody is not even intubated, okay, you can decide to encourage the person to breathe. That is the essence of physiotherapy. You tell the person, now try to breathe. Now, if you discover that, because the patient may be sleeping, maybe you discover that patient is sleeping too much, you try to wake the person up and tell him, try to breathe. You do physiotherapy, exercise the person. By the time you do, the patient will keep awake and be breathing. And by breathing by himself, he will be able to blow up. So, but when it is in certain level, you must either give sodium bicarbonate, or you want to take over even the airway by intubating the patient. Maybe some people will tell you, patient is conscious. It's not only because patient is conscious, you will not intubate. If there is excessive CO2 accumulation, even though the patient's GCS is 15/15, you must do well to blow them up. And one of the best way of blowing them up is to intubate the patient. You set the rate yourself. You set the tidal volume yourself. You can paralyze the person. And then you blow them up. Otherwise, CO2 intoxicity, then the person will have problem. So you must try to correct. But it's not every time you start giving sodium bicarbonate or you start intubating. You must now look at, is there other things you can do? Physiotherapy, exercise, encourage breathing, incentive spirometry. Those things can help the patient to keep awake and breathe. Okay? Now, when you have discovered some of those abnormalities, okay, what is your plan? Yeah, the truth is that we work as a team when it comes to critical A patients. There's nothing wrong that you ask questions, you make suggestions. In fact, currently there is an ongoing critical care training mentorship that is going on. You know, for the first phase, we are doing it. You know, it's being done in about I think 7 centers in Nigeria, in connection with Mayo Clinic USA. And then so there's usually simulation of what round should be like, what patient care should be like, what should be doing. So you discover that it's actually a teamwork, that if all of us have knowledge and information and there's suggestions you brought, then each person should be able to buy into that suggestion. You can ask questions. Okay, have we corrected or are we not correcting? Okay, why are we not correcting? You understand? You can, so somebody may see, understand, but he's planning, but his mind goes off, or he didn't remember, or his mind didn't even understand the figure that is there. But by seeing it, you understood it, you now make a suggestion, you ask a question, okay, then the person will be able to implement it. Okay, like in the first phase of this training we're doing, we have for now in UNTH, we have only one physiotherapy in the training, then we have some nurses, and then we have some doctors. Okay, maybe in the next phase, we will also bring other team of the critical care team to be part of that mentorship and simulation that is going on. Okay, so but like I said, it's a teamwork. So everybody, once you see that there's a problem, the knowledge has equipped you, you can ask questions, you can make suggestions to the team. Okay, now the relevance of anion gap. Yeah, anion gap helps you to understand, because remember, when you calculate the anion gap, the next thing is delta ratio. And what does delta ratio help you to know? It helps you to find out whether there are mixed problem. Is there other conditions? So when you discover that there are other conditions, maybe kidney problem, lung problem, or the problem is chronic, because I gave out the value, which if you calculate your delta ratio, because once you find out there's an ion gap, the next thing is calculate the delta ratio. So if you calculate the delta ratio, which is the change in anion gap over change in bicarbonate, okay? Anion gap you calculated, you subtract 12 from it. Then the sodium bicarbonate that is in the value, you subtract it from 24. You get the value, depending on whether it is 1, less than 1, 2, or more than 2. You can now decide, okay, this is the condition. So that will now guide you. Okay, maybe you can go up to the next slide so that they can now see the importance of that anion gap. Just take this slide up. Yes, you can now see, once you do your delta ratio, you now see there is what? Anion gap. So, okay, it's just anion gap, so there's nothing much problem. But if you see, oh, it is a mixed problem, or there are other conditions, okay, or there is other metabolic problem, so which means it's not just this thing I'm seeing, maybe metabolic acidosis, that there are other conditions, kidney problem, renal, maybe diabetic ketoacidosis or other things. So it will now guide you to be able to now troubleshoot and then manage the patient effectively. Sorry, thank you. Okay, yeah. So take the slide down so that I can now show us. I don't know if we still have time, but that's the slide. The next, that example. The slide down. No. Oh, we lost it. Because I wanted to show us that someone that was talking about the example that he said he didn't follow because people were crossing the answer, so he or she did not understand. Just but if we cannot get the slide back, then I would have shown the interpretation of that last two.
Let's just give him a minute and see if the slide can come up.
Okay.
Let's just hold on. Let me know what's going on.
Down. 29, slide 29. Yeah, no, slide 29. Yeah.
29.
That place you have examples. Yeah. Yes. So I see, yes. Yeah. Second to the last. Sorry, second to the last. Second to the last. So pH is 7.2. So I said pH is going down. So it's acidosis. pH is going down. Okay. Now PCO2 is 25. It is going down. So it is not a respiratory problem, because if it is a respiratory problem, PCO2 should be opposite to pH. Do you understand that? Then the next one is bicarbonate, which is 10. Normal is 22 to 26. So bicarbonate is coming down. pH is coming down. They are in the same direction. So pH bicarbonate is equivalent or equal. Following the modified Henderson-Hasselbalch equation, pH is directly proportional to what? Bicarbonate. So it is what? A metabolic problem. And we say this metabolic acidosis because bicarbonate going down means it's acidosis. If it is going up, it means alkalosis. So now the PCO2 is down, which means the lung is trying to blow off carbon 4 oxide to compensate. But this compensation has not been able to restore pH to normal. So I said it is what? Partially compensated metabolic acidosis. Okay? That is for this one. Then for these two, now pH is down, so it is acidosis. Now PCO2 is normal. It is not going down, it is not going up, it's within normal range. Now bicarbonate is down, so it is what? pH is down, bicarbonate is down, so in the same direction. So it is what? Metabolic problem. So it's metabolic acidosis. But now look at this. PCO2 is within normal range, so there's no effort by the lung to even blow off carbon 4 oxide to compensate. So I said this one is uncompensated metabolic acidosis. Why this one is partially compensated metabolic acidosis. All right. So you can do well. Just read up. You will be able to understand. Thank you very much. My pleasure.
Thank you, sir. Please, can we appreciate him with any emoji? We're already behind our scheduled time. We want to appreciate Dr. Okonna for his time. And you always agree with me that he has done a good job. He is a team leader and he believes in teamwork. So he's our head in our ICU and UNTH. He's someone that believes that you have something to offer. So whatever it is, bring it on board as long as patients get well. So we really thank you. And for us as physiotherapists, I was glad when he mentioned it. When we look at ABG, ABG guides the intensity of treatment we give. It tells us when and it tells us how. So if we have a patient that has low partial, for example, partial oxygen, partial pressure of oxygen, we will know that this is time to do a lot of deep breathing because we want to get oxygen in. You know that this patient should not lie supine because the partial pressure of oxygen this patient is low. If a patient, if you look at ABG and is acidotic and is coming from the lung, that is, there's increased level of CO2. You need to start asking yourself what is happening. Are there secretions? Is it that patient cannot cough out? If a patient that is on ventilator, it tells you how many times you nebulize this patient with a hypertonic solution like normal saline. Sometimes we use normal saline to nebulize. So knowledge of ABG guides us, and when we treat and the test is repeated, it also helps you to evaluate if what you have done is correct. So any physiotherapist that is into cardiothoracic into management of patients with cardiopulmonary issues and critical care, you should, know how to interpret and use ABG to guide your treatment. Please, Dr. Okonna, we have a group and we are going to add you, because before now, we've always had issue with ABG interpretation and analysis. We are going to add you to that group because I still have more questions coming on as we were talking, and we can't take them because if I continue, we'll be here till beyond 9 p.m. So please, you allow us to add you to the group so that you can take these questions on the group. The group is a very quiet one. We're very interested in learning. The group is not open to any other business apart from learning. We have questions for our last speaker, Dr. Nwa, for the pharmacy, but I've not had time to post them. And I'm glad she's already in the group. So when these questions are coming, please, I'll call your attention to take these questions so that we continue learning. So thank you, everyone. This is our last presentation for the year. And with just in our tradition, we're going to resume again by the special grace of God, February next year. We usually leave January out of it so that people can sort themselves out, do a lot of New Year resolution, and get themselves ready for the year. So I want to thank everyone for staying with Cardio Group for this whole year and being very wonderful participant, audience, and students. So thank you. Thank you to all our resource persons that have really helped us this year. Thank you for all the contributions and the questions. I really appreciate it because without you, there is no Cardio Group. So good night and have a wonderful Christmas holiday. See you next year, bigger and better. Please, let's appreciate each of us with a wonderful emoji of our choice. And thank you, Dr. Okonna. Good night, everybody.
Thank you.
Good night.
Thank you,
Thank
Dr.
you.
Okonna.
Thank you, everyone. Good night.
Good night.
We are going to make sure that the answer goes through. Bye. Good night.
Thank you. Good night.
Thank
All
you.
right,
Good
thank
night.
you.
Bye.